Good morning from me. I've said good morning to some of you before. For those that I haven't, good morning to you. For those that were in the other two rooms, I'm afraid a slight breakdown in communication. But from my point of view, because I should have started by wishing all those mothers in the room a very happy Mothering Sunday, which I didn't, and for which I apologise. But I'd like to go one stage further and say that Green and Blacks have very kindly donated some little chocolate bars to us for the mothers. But I hasten to add there are enough there for the fathers and the sons and the daughters as well. So if any of you are not in this room, then at the end of this session, please, there are little bars of chocolate on the side. Please help yourself. Apparently, I think it might have been Carolyn Young who said that chocolate isn't so good for you, and sugar rushes aren't terribly healthy. But apparently, she loves chocolate in any case. So all I can say is I love chocolate. I'm going to go and grab myself a bar. So welcome back. Thank you for coming back after coffee. We now really are in the final run today. We've got Dr. Annie Jacobs. He's going to talk to us. I won't introduce him because he's already introduced himself up on the screen. But he's going to talk about TM research in the UK. And then you can probably sense from here, we're going to get as many of the speakers who are left with us to have one final crack, one final opportunity for you to ask them those questions that we've been wanting to ask all weekend. So without further ado, Anna, can you take us through this? And I wish you all the best of luck.
I'm Anujay, as mentioned. I've been asked to talk about TM research in the UK, but I'm going to expand on other things. Now, I've been asked to talk in 15 minutes, so there isn't probably much going on. I'm from Liverpool, please don't hold it against me. And in Liverpool we had this fantastic waterfront. I used to put another picture before, but we don't talk about football anymore. There's a waterfront in Liverpool. The Walton Centre, as Carolyn must have mentioned, is a very large, the largest standalone neurocentre in the country. 25 neurologists, 15 neurosurgeons, and you look after that area of the country, the northwest. 3 million people, and you look after 13 district hospitals. So I'm going to the other things first. I've been asked over and over again several times during this conference on a condition called neuromyelitis optica. And I want to dedicate a few slides to it, because it's particular pertinence of that condition to those who have TM. So NMO is basically classically long myelitis and optic neuritis. That's a classical definition. And that is the long myelitis, that's the spinal cord there, that's a long area of inflammation. And you also get optic neuritis at some point or the other in the course of the illness. But the very first instance could be myelitis, and you have no way of knowing, but until recently, whether you're going to get a further episode or not. So features of NMO are usually a relapsing condition. Can be relapses of either optic neuritis or myelitis. And we have this antibody in the blood, anti-alpha-4 antibody, which helps give us the diagnosis much earlier, even after the first episode. And also helps, in some respects, gauge treatment. So the point I wanted to make was, if you have one episode of TM and you have a positive antibody, then it's called NMO spectrum disorder, and it might require a different line of management as opposed to classical post-viral common garden TM. So how does this condition evolve? You have these B cells, white lymphocytes, lymphocytes, white cells producing this antibody. So these antibodies are produced and they go into circulation. That is the blood vessel Okay, that is the cell circulating, the white cell, producing antibody. It's called aquaporin 4 antibody, or NMO IgG in the States. So it gets into the nervous system inside the brain, and it goes and attaches to this aquaporin. It's basically a water channel on the surface of the astrocyte. Now, we heard a lot about astrocyte yesterday. That's the astrocyte inside the brain. That is the water channel, the aquaporin 4, and the antibody binds to it, causes inflammation, causes demyelination, and so on. Ultimately resulting in myelitis, and if it is the eye, the optic neuritis. NMO, I must say, is a worse condition than TM for obvious reasons, because we have relapses in NMO. NMO patients have a TM and optic neuritis, and NMO requires long-term immunosuppressive treatment in the vast majority. For to treat relapses, we give steroids, we can use plasma exchange, and you can prevent relapses by medications like azathioprine, rituximab. This is a paper we wrote a couple of years ago, which is pretty effective. We can use mycophenolate, another paper we wrote on the subject, and these are efficient in preventing relapses. And now we have this, because of the rare condition, and it's less than 1,000 in the country, we have acquired funds from the government, run a national service based in 2 centres. One is in Liverpool, the Wharton Centre, and the one is in Oxford. People north of Birmingham should be coming to us, and we recently did a clinic up in Aberdeen looking after patients there. So if you have a suspected diagnosis of relapsing TM or NMO, then I think this is something you need to consider. What happens in the clinic? We have a 1.5 million funding. We have 4 adult and 2 pediatric consultants. We have specialist nurses. Kerry is here today. Therapists. The MDT is the one-stop shop for people who have this condition or similar one. And we also collect samples for research. We are planning for clinical trials and so on. So I think from a service point of view, NMO is far advanced than TM. That's about NMO. Number 2. TM in the UK. Now, we know little about TM in the UK. There aren't really many studies. It's not something that's researched widely. There are small publications or small collections of patients scattered. And perhaps the largest resource is probably the society itself, who has a large database and information. Because of my interest in NMO, I wanted to sort of look further into transverse myelitis at the Wharton Centre, and start from home. How many patients are there? What are their symptoms? What treatment did they get? And how did they do in the long term? Now, the Wharton Centre, as I told you, looks after 13 other BGHs. We go there and do clinics. So we're not including patients from those hospitals in the study I'm going to show. The first instrument I did was I just looked at the medical records electronically and found how many patients had the diagnosis of transverse myelitis. And I was really surprised. I got 324 records. It's a huge number from the hospital database. So I spoke to TM Society, and I came to London to speak to the meeting, and they agreed to fund the research, to find out more about these patients. I'm very grateful for that. But when we did the proper study, we found that more than 68% of the so-called transverse myelitis and electronic medical records were actually compressive myelopathies, things like discs and tumors and so on. And this is the large neurosurgical center as well, so naturally some of the coding has gone wrong, or the information was put wrongly. So we're left with 32%, 102 patients who had non-compressive inflammatory myelitis. So myelitis in some respect. Looking further, look at C12. So the myelitis group, the so-called myelitis, was 324. We have a non-compressive 32% and 68% there. And breaking this group up, we have a typical TM, 29%, or 30 patients. Those who presented with an episode of TM, who later on, at 18 months of follow-up, developed into MS 58%, NMO 11%, and others around 2%. So only 30% of those who had a non-compressive inflammatory myelopathy at presentation turned out to have typical TM in the long run of 2 years. So this is a graphical representation of the same thing. So predominant non-compressive myelopathies, MS being the main thing, and TM being a subgroup there. So how did these people do? There's only 30 patients, nothing like Doug's 2,500 patients, but this is what we have from our large center. Median age, 46, 60% women, 30% had a trigger of some sort causing the episode of TM. Predominantly sensory symptoms at onset, that is tingling, numbness and so on. 20% had weakness as the first symptom, and 4 patients had pain as the first symptom. 16 patients had significant bladder problems, and 6 out of 30 had only sensory problems as a feature of TM. So we decided to rate what is the disability in this group. So there's a scale called the Hughes scale, and 0 is normal, 1 is minor, 2 is can walk 30 feet without any assistance, and 3 is needs assistance, and 4 is bed-bound or wheelchair-bound. So I decided to class all this 30 patients that I had into the subgroups. We found that the Hughes 1 and 2, that is the mild variants, were 50%, and the more severe form forming the other 50%. So 50% at least are significantly affected at the nadir of the illness. What treatment did they get? 19 of the 30 got steroids, and all those who had significant disability went on to get steroids. And those who had minor disability perhaps didn't want to have treatments, or they recovered pretty fast. So only 1/3 of the minor group got treatment. And 1 patient only had plasma exchange, though there were 14 who had quite a severe myelitis. How long did it take for them to come into the medical attention? I mean, when they go to the GP. So the median is about 1 day. Probably they went to the GP in the first day itself. But the range is quite wide. Up to 44 days it took for them to get some sort of attention. 20 of this 30 in inpatient admissions, the other came to the outpatients, and the median hospital stay was 16 days, okay, a range of to 170 days. How much time from onset to treatment, steroids? For 6 days. And almost all patients had steroids by about 4 weeks. Nobody required a ventilatory support, and there was no mortality. And about 56% got transferred into rehab from the hospital itself. MRI scans, predominantly cervical neck lesions, some in thoracic, some had no lesions at all. Perhaps we did the scans too early, too late, scan wasn't good enough, we don't know the answer. At 18 months, as the median follow-up, the retrospective study, I'm looking at the records now and looking back at what has happened. From the records, what we understand is that there's improvement from 3 to 2, that is walking with assistance to without assistance. In a good number of patients, an exact percentage, but 93% are left behind with problems, and pain and bladder symptoms being the big part. And 72% need some medication or the other. Pain, spasm, stiffness, depression, bowel, bladder, all are significant. And 12 out of the 26 people whom we know of, who were in full-time work, couldn't get back to work. So 50% of patients whom we know of, who were in full-time work before, couldn't go back to full-time work when we know at 18 months' time. So it's a significant problem. So my conclusions from this study was that medical records are inaccurate, at least from the diagnosis point of view. 30% of acute inflammatory myelopathy is TM. TM can be the first sign of many other conditions, and treatment is only modestly effective. Plasma exchange is underutilized. I think this is one message we have to get across to clinicians and people who care for TM, to have early plasma exchange, particularly in the group that is severely affected. And the vast majority will have some form of residual disability. We've already presented this information in various meetings, just trying to educate other colleagues.
What does the bottom line on that slide say?
Presented at 2 national meetings.
Oh, all right.
Okay. So one was a nurses meeting, one was the Association of British Neurology meeting in Southampton, I think, last year. Right. So what's the way forward? It's clear there's a dearth of understanding about TM in this country. We have people with TM, very motivated, committed people. We have clinicians with interest, myself, me, and several others, I'm sure. We have scientists, excellent work in the MRC lab. There is money out there, I'm sure. Companies are there from charities, donors. Yes, we can raise money through various issues. But there is no unifying factor here. There's nobody to guide, put a photo. So perhaps the society, you should already help coordinate this movement into something like what the MS Society is doing for MS, and the R service, the government-funded NCG service is doing for NMO. So we need to look into that, and I'm going to leave that with the society to take it further. Hopefully, we will have a forum for clinicians to discuss, throw ideas across to each other. Okay, I'm going to study, what are you going to do? Shall we collect and do the same thing? Let's collect the whole, all the TM patients in the country. We can send out surveys and so on. We need to involve the centers that are already doing research in TM to come together. I'm sure Doug is going to ask me, maybe 6 months, 7 years time, I know I'm going to start this trial in Lingo. Do you have 50 patients who have definite TM, who are wheelchair dependent, who have no other medical problems? And I don't know the answer. I don't have it. So I need to collect those patients, characterize them, and it is every clinical RCT or clinical trial specialist's dream to have a well-characterized, homogeneous group of patients, and we don't have it present. So hopefully we can create all that in time for clinical trials, which might ultimately is what all we all want. That's my few last slides. my kids don't have to do their homework today. My wife doesn't have to cook. We're going to buy curry and distribute it in our restaurant. We run the World Cup.